Hello, future nurses coming in, and we're going to start in on Unit 5. Again, this should be a very quick and brief review, just kind of going over what we went over in lecture. So Unit 5 starts with trauma, stress, dissociation. There is a lot in this section. When we look at trauma, we're going to look at our adverse childhood experiences, and there are 10 of them. And these are 10 things that if they happen to you before the age of 18, they have just huge, long-standing repercussions on your life. And honestly, there's even more than this. We have the 10 original, but now they're looking at how other things come into play, and how it just affects all of us. So when we look at our adverse childhood experiences, this is from the CDC. 61% of adults had at least one of those adverse childhood experiences. 16% of adults had 4 or more adverse childhood experiences. Females and several racial ethnic minority groups were at greater risk for experiencing 4 or more. And many people don't realize that the exposure have those increased problems across your lifespan. Our adverse childhood experiences are linked with up to 21 million cases of depression, 1.9 million cases of heart disease, 2.5 million cases of obesity. There are a ton of research out there that says if we decrease ACEs by X%, we save these billions of dollars in high school, in financial costs. So when we look at trauma in children, we know PTSD, this is a diagnosis that's very common. We're going to be talking about PTSD specifically in children. We're going to be talking about something called reactive attachment disorder and disinhibited social engagement. Trauma often precedes so many psychiatric disorders, especially in children. Abuse, interpersonal violence, car accidents, natural disasters, war, medical problems, illness are all traumatizing events for kids. And we do see those changes. And the thing is with kids, they often blame themselves. So it creates this cycle. When we look at that epidemiology, we don't really have prevalence rates for how many kids have PTSD. However, adolescents, we have a rate of 5%, and it is higher for girls than boys. We have some numbers. 100% of all children who witness their parents' murder or sexual assault will develop PTSD. We have a lot of comorbidities: nightmares, trust, phobia, somatic problems, impulse control, identity issues, learning, attention, behavioral, sleep, depression, suicide, dissociation, and substance abuse. Etiology goes back to a lot of that diastasis stress model, that nature versus nurture. Do you have a family history? Was it a Erickson issue? Trust versus mistrust is a big one. Did you have a supportive environment? Did you have supportive parents? All of it. Genetics, how we react to trauma. That rapid brain development in the first 5 years makes kids particularly vulnerable. We're not necessarily going to go into some of these really long theories on it. They're good to have in the back of your mind. But polyvagal theory is not something we commonly are just going to talk about. However, we see how trauma dysregulates the brain, how it leads to hypoarousal, disassociation, all of that. Those psychological factors. Attachment theory is Erickson. That a lot of it's that trust versus mistrust. Kids in those first 2 years learn to trust. If the kids does not learn to trust, they wind up with this negative viewpoint of the world. Kids have a dependence on their adults and their support systems around them. Young kids can often do things on their own. They're often vulnerable in their environment. So we do have some environmental factors that can add stress to that child or can take stress away, can support their child. Parents often model behavior and provide children with that viewpoint of the world. So when we're looking at our assessment, we're going to do a developmental assessment on pediatric patients. We want to know where they are. Are they at the same point that their peers are, or are they below it? Do we have a kid who is not potty trained and they're 7? Do we have a kid still sucking their thumb, parallel playing? This is not pediatrics. We will not be doing a developmental assessment. We just have to know there's a thing. With these kids, when we collect data, we very much want to interview, screen, test, observe. You can oftentimes watch a child and it gets a lot of information. How are they interacting with their parents? Play therapy. We do want histories from several sources. We want to look at PTSD symptoms, nightmares, hallucinations, intrusive thoughts, flashbacks, trauma reenactments, and play is a big one with kids that we're going to be assessing for. These are unfortunately the Barbie dolls who are having sex. We're looking at pictures. Is this kid drawing a picture that they should just not be drawing? From there, we can go and look through. And again, like always, our nursing diagnosis outcome implementation evaluation is going to be based on that assessment that we find with the kid. So what are we doing for these children? We're going to provide safety and stabilization. We want to keep them safe. Safety is always one. We want to reduce arousal. We went through it pretty fast because of how they had that slide. We're kind of going into PTSD now. If we often see hyperarousal with PTSD, you're very on alert. You're always looking for what is happening. We want to help calm the patient. We want to reduce all of their negative symptoms, their nightmares, their flashbacks. One of the most important things with kids is we want to catch up on the skills. If they have lost skills through all of these things happening from having to deal with the trauma, we want to get them back to a nice, good, and stable point. So when we have the child with PTSD, we want them to trust us. So we're going to develop that therapeutic relationship. We're going to keep them safe. We have to talk like we're talking to a kid. Are you having intrusive thoughts? A kid is not going to know what intrusive thoughts are. Are you having nightmares? We will always teach relaxation. Play is amazing with kids, getting them to express feelings, toys, video games. It's just a great way to assess them. If we more so have kids with PTSD, we always want to involve the caretakers unless they're the cause. And we do know that statistically the biological mother is more likely to be the one abusing a kid. So if the trauma does involve the parent, we need to move them out. We have to talk about the grief process. And it's funny to say we're talking about the grief process because oftentimes we have caretakers, right? We have the parent, the kid who just had something happen, maybe external to the family, and now the parents are grieving their children's childhood. We have to talk with everyone. We have to coordinate with social work. We are all mandated reporters. So depending what the trauma is, we may have to report that trauma. So what is attachment disorder? Attachment disorder, specifically reactive attachment disorder, is a failure in trust versus mistrust. In reactive attachment disorder, it's generally within the first 8 months of life. There is a lack of bonding experiences with a primary caregiver. So we can go back and think Romanian orphanages, there's a whole bunch of research out there about those kids. They were dumped in this orphanage in Romania. They were left there to cry. No one fed them, no one changed them. The adults and caregivers really didn't seem to care about them. So this child with reactive attachment disorder does not know how to bond. Holding therapy, it says it can be controversial. I've worked when I did long-term care with a lot of kids with reactive attachment disorder. It was a common diagnosis, especially when it was elementary school kids. However, I've never seen holding therapy. It is essentially restraining the child. The child is going to be forcibly held by the therapist or the parent. And through this forcible restraint or confrontation, we are going to reduce a certain rage about that that results eventually in release. We want to make the child become infantile, cradling, rocking, or maybe even bottle feeding them. Like I said, we did therapy, not holding therapy. Disinhibited social engagement disorder is similar to reactive attachment disorder in that the child never learned to trust. And in reactive attachment disorder, they never learn to trust, so they don't trust anyone. In disinhibited social engagement disorder, they never had anyone to trust as a child, so they trust everyone. There is 100% no stranger danger. No normal fear of strangers. They will go with people unknown to them. They're not going to check back with adult caregivers. They're going to seem unfazed by separation because they very much are by attaching to everyone. I'm not really attaching to anyone. So we're switching gears from kids to adults. PTSD is again one we are very more familiar with. It's experiencing of trauma. One thing to remember about trauma is it could be the threat. We could see something And that is enough. It doesn't always have to be happening to us. We could be aware that the trauma is happening to someone else. However, in PTSD, we tend to see this hypervigilance, this avoiding of stimuli. I was in a car accident at this location, so I don't drive there anymore. Fear, helplessness, horror. We do tend to think military, however, natural disasters, human disasters, life-threatening illnesses, sexual assaults. We have a bunch of them. 55 to 90% of people in their life will have at least one traumatic event. So that's pretty much all of us. How we respond is variable. We have a lot of comorbid conditions that go along with this. Depression, anxiety, sleep, substance abuse. We often see substances being used to help manage anxiety. I think the American Psychological Association estimates that in 2018, we spent $23.2 billion on post-traumatic stress disorder in the United States among U.S. civilians, active duty, and veteran. So through everyone. So that is a lot of things that we see. We tend to see a lot of guilt. I should have done this instead. If I wouldn't have gone to the party, then I would not have been raped. If I would have not hurried to get to this place, I would not have been at that intersection. I would not have been at in that car accident. With PTSD, we do, and again, these are very generalized to the condition. It is going to be individualized to each person. But a lot of that guilt is a big one. Outcomes we want to manage anxiety. Self-esteem will always be it, and we want to help the patient cope. They may not be coping in the same way. Our implementation is going to be that same three-stage model for kids. We want to keep them safe. We want to do a lot more psychoeducation. Psychopharmacology, we do have some specific meds. Prazosin is a blood pressure medicine, but we've learned that if we give it at night, it helps with nightmares. EMDR is a specific therapy, eye movement desensitization, where the patient's using movements of their eyes, tapping, to help work through that trauma. It is not an easy process to work through trauma. This again is a patient, kid or adult, who does need therapy. Some of these videos. Acute stress disorder. Acute stress disorder is a time frame. Type of traumatic event, we have emotions, we have thoughts, and we have feelings. If they resolve, it's over. If it does not resolve, it becomes PTSD. So acute stress disorder is the first few days after a traumatic event. You are in a car accident, you're hypervigilant, you're afraid to get back in the car, you can't sleep. However, you eventually kind of get over it. It is what it is, it happened, and you move on. So you had acute stress disorder within that first 30 days, and then acute stress disorder ends. Now, if you were in that car accident and the symptoms continued past a month, we would have that acute stress disorder for the first 30 days. After 1 month, it changes and becomes PTSD. This very much just compares the two of them. Acute stress disorder is in the first 30 days, 28 days. It lasts for a few days to a few weeks. It's very short term. Post-traumatic stress disorder, it's at least a month, and it's going to occur for at least 1 more month or several years. Much more avoidant, changes in moods, long-term medications, and therapy. These are some nursing diagnoses that we can see in acute stress disorder: anger, dissociation, headaches, irritability, nightmares, and it's related to potential being a victim. If we have acute stress disorder, this is usually right after. We want to establish a relationship. We want to teach the person to problem solve, make sure we get to supports. Honestly, after any type of crisis, the first thing we want to do is assess for safety and develop that relationship. We're going to keep ensuring we maintain safety. These are not in order. Safety and relationship are first, then we problem solve and connect. We eventually want to get to that tertiary type prevention, make sure they're seeing a provider, make sure they're staying with treatment, make sure they're going. Cognitive behavioral therapy would be what we would want to do with this patient if we're going to name a type of therapy. But we want to get our patient with acute stress disorder into treatment early, because then hopefully it does not become PTSD. That is our goal. Adjustment disorder. Adjustment disorder is a mild, less specific version of acute stress disorder and PTSD. It talks about how it's precipitated by a stressful event, but y'all, a stressful event, retirement, chronic illness, breaking up with your boyfriend or girlfriend. Um, and it's how we respond to this stress, depression, anxiety, all sorts of things that can come into it. We can see this after death. If we have adjustment disorder with grief is a thing where we might see someone who are not celebrating their holidays. They're not celebrating Christmas. It is so traumatic not having my husband with me. I don't want to celebrate anymore. And as we adjust with this grief. Many of you all may have seen this movie, Riley. We'll watch these clips in class if I can get the speakers to work. Riley's from Inside Out. There is a new movie coming. Riley was a very well-adjusted kid, and then her family moved her from like the Midwest to California. She struggled to make friends. She wasn't enjoying the activities she used to do. She had agitation. She had uncontrolled emotions, and it differed from her normal behavior. So when we look at Riley in this movie, well-adjusted kid, she moved, she is no longer adjusted. That would be adjustment disorder. Do you get a new job? Do you move to a new state?
Some psychology articles have stated.
Flip through those videos. We're not going to watch them now. Dissociative disorders. If we're looking at what is dissociation is very Freudian. It is an associative adaptive response to overwhelming events to create normalcy. Dissociation isn't bad. All of us probably disassociate on a maybe not regular basis, but at times. If you've ever had a bad day from work and you're driving home, and next thing you know, you're like, I don't remember driving home from work. I'm home. Dissociation. If we have a kid whose parents are abusing them, they may very well disassociate because they need to still live with those parents. And it kind of helps them forget about the different things that are happening. It is unconscious. It helps with that overwhelming anxiety. We are able to separate our emotions. This is very much a long-term chronic illness. We want the client to progress very slowly through this. Disassociation is involuntary. And the symptoms can be either positive or negative. You'll see as we talk about some of our different dissociative disorders, what I mean when I say positive or negative. So when we look at what those dissociative disorders are, what we're going to talk about today is depersonalization and derealization, dissociative amnesia, and dissociative identity disorder. This is a vignette from your book. We'll look at it in class. Y'all can pause and take a minute if you really want to look at it now. So depersonalization is a focus on ourselves. We're uncomfortable with our own body. We feel like we're an observer of our body. If we're talking about depersonalization, maybe it very well is that out-of-body experience. This stressful, traumatic event happened, and I felt like I was watching it from above. Derealization has to do with our environment. I feel like I am walking in a bubble. I feel like I'm walking in a fog. There is an invisible veil between me and the rest of the world. We have a 2% prevalence. These aren't extremely common, but they do tend to go away on their own, and we do see them more frequently when we look at a lot of those adverse childhood experiences. So dissociative amnesia. It is amnesia. I don't know why when I was a kid, I thought if you got hit by a head, you got amnesia, but this is what it is. We cannot recall important personal information. We forget that we're married. We forget what happened last week. It very much is going to depend on what it is. Generally, this is caused by some type of trauma, and they spontaneously regain their memory. In the video we're going to watch in class, there's someone and they're talking to her about school. She's like, school's stressful, applying to college, SAT. And they're like, what happened at school last Tuesday? And she's like, nothing happened at school. From the conversation, we're going to assume that something happened at school. She just does not remember it. So in dissociative amnesia, we can't recall that personal info. We have a form of trauma. We slowly get our memory back. These occur at every age. There is no specific age where some of these dissociative disorders are going to happen. You'll see when we talk about depression, we'll be like this age group. When we get to schizophrenia, we have this age group. Here, any age. Now, we do have a subtype of dissociative amnesia called dissociative amnesia with a dissociative fugue. And a fugue is unexpected travel, but you're not aware that you're traveling. The Jason Bourne movies, the Bourne Identity series, is based off of a dissociative fugue. Something happens and you take off. I tend to tell y'all, we realized it's helpful if we remember fugue as fugitive or fugue as far away. Some individuals with a dissociative fugue go so far as to have a new life, have a new family. And the difference is in dissociative amnesia, we can't recall personal information, usually about a specific event. In a dissociative fugue, we forget our autobiographical memory, which means we don't remember anything about us. I don't remember my name. I don't remember my birthday. I don't remember my parents. I have forgotten 100% of who I am. In the Bourne Identity, Jason Bourne forgot who he was, but he still remembered that he was a CIA-trained assassin. He remembered all of his moves. His training. He might not have remembered, I am specifically this assassin, but he remembered how to fight. And that is that dissociative fugue. Let's do some of these videos. Dissociative identity disorder. Dissociative identity disorder, often called DID, is a little confusing for y'all because you know it as multiple personality disorder. In the DSM, we just have a different name for it. And these are clients who are not always aware of their previous trauma. They have periods of time they can't remember. And again, it's an unconscious defense mechanism. These patients oftentimes sexual assault and physical abuse as a child. And the child's brain can't take it. So what does it do? It splits. And if you've never seen it, this picture right here is from the movie Split. Not a bad movie, but not the best when we look at DID. So this patient has all this trauma. They might not understand why. And we have two or more personalities, which is within one body. And we have a host who is the main person. We'll watch a video in class. The host is Jennifer. And then Jennifer has alters. She has muscles. And she has, I forgot some of the names. I used to know the names. But she has all these different people who live inside with her. The brain literally splits itself to protect. Remember, when we talk about dissociative disorders as a whole, these are adaptive responses to overwhelming events to create normalcy. If I have a child who's being sexually assaulted by their parents and their brain splits to protect, and what we see when we look at the video with Jennifer, Jennifer was being assaulted by her dad. Jennifer then does not have to live with the trauma. Jennifer forgets the trauma and muscles. Muscles is nice and big and protective. That is one of Jennifer's alters. Muscle undergoes the trauma. Muscles get the negative stimuli. And that allows Jennifer to still live with those abusive parents. I know we're going to think it's bad, but our body is doing this and our brain is doing this to protect ourselves, to create that normalcy. Personality will be different. We had one actually at one of our clinical sites probably about a year ago who would sometimes need a wheelchair. Sometimes they could talk. Sometimes they were a toddler. Sometimes they were 70. So it's going to be different. We see dissociative disorder not just in Split, Fight Club, the United States of Terra. We have a bunch of movies where we see this. Sybil, many of y'all I know have not seen it. It's one of our first movies. And in watching some of those, we see how individuals and families interact with some of these patients. And there's some things that they do are good and some things that they do that are kind of bad. We don't always want to talk about the forgotten events. The client is the patient will have forgotten things for a reason. And maybe it's what they did while they were not in control. Jennifer's going about her life. Muscle takes over and does something. We don't always want to talk to Jennifer about what Muscles did. We do want to teach a lot of grounding relaxation techniques with this patient. They do tend to switch between personalities when they're unstable, when there's something disruptive going on. One of the first episodes of United States of Terra, she's a mom, she's off her meds, she has dissociative identity disorder. She finds out something about her daughter. And it was something that happened while one of the other personalities was in control. And she was like super stressed, and that caused her to switch to become someone else. We can see more so in the United States of Tara whenever she gets stressed, that's when she switched. So we want to teach those grounding techniques. And honestly, most importantly, we don't want to let them make major life decisions. This is not the time to like go buy a new house when we have one of the alters in control. That is a very bad idea. That's Jennifer. We'll watch her in class. So when we look about dissociative disorders, our lifetime prevalence of all of these is like 2 to 10%. We have a lot of comorbidities: depression, panic attacks, eating disorders, PTSD, OCD, reactive attachment disorder, ADHD. We do see personality and substance abuse, sleep and sex with it too, some sleep and sex disorders. Our pretty much risk factor is childhood physical, emotional trauma and abuse. Any type of traumatic life events with adults are associated with dissociative symptoms. There are no genetic factors. I don't even know why we put these here, except for me to tell you there really aren't any. It's all going to be due to those extreme stress, to those environmental factors. That is what is causing it. So again, when we look at the psychological factors, this is Freud. It is those ego defense mechanisms. One of our defense mechanisms is disassociation. And at the simplest, disassociation is a response to overwhelming trauma, a response to those overwhelming environmental factors. Car accidents, combat, abuse, incest, neglect, abusive caregivers, imprisonment. We have a caveat that there are certain cultural considerations that must be taken into play. We do have some cultures that practice, have different cultural practice that involve a trance-like state. Your textbook specifically talks about frenzy witchcraft among the Navajo. That is different than disassociation. So we just have to be aware, if we do have a patient who is practicing this, it is not always disassociation. So when we look at those dissociative disorders, we have to get the history. What is going on with your patient? What has happened with them? Employment problems, different problems with school. How is this impacting their family? Suicide. Suicide is always a big one because this follows trauma. Self-assessment. It's really hard to work with these patients. We need a very, very, very slow workup to get them through everything. So it takes time, and we're taking baby steps. We have tiny goals. So we just have to make sure we're taking care of ourselves. So if we're planning our 3-step planning, phase 1, safety and reduce symptoms. Phase 2, we want to try to work through the trauma and integrate the memories. Phase 3, we want to have one person, one identity. So if we're talking about dissociative fugue, I want you to remember who you are. If we're talking about dissociative identity disorder and Jennifer had 6 personalities, we want to start integrating all of those personalities into just Jennifer. And that's our goal with dissociative identity disorder. Psychoeducation. We have to talk. There are no medications specific for these disorders. We may give medications based on symptoms, but this is a lot of long-term therapy. CBT, exposure, EMDR, hypno, neurofeedback, all sorts of different therapy. It does not just go away. There is no popping a pill. These patients need therapy. We got some questions. I know we went over these in class. I'm going to skip through them really fast. And I am actually going to stop this video here at 30 minutes to not muddle it up. So we will do a separate video with our somatic symptom disorder. This one specifically did trauma and disassociation. If y'all have any questions, please let me know.